Again, welcome everybody to this seminar today, and I thank you all for being here. That's really great. So my name is Karen Wall, and I am one of the professors at WISR University, and I teach in the MFT graduate program. I see some of my students here, which is awesome. And just a quick review of myself. I've been an MFT licensed since 2016. I have a private practice. I do telehealth. So my practice is online. And I'm one of those techno geeks that uses a lot of mobile apps and stuff like that. And I'm also, I'm a psychiatric nurse too. That was my first trade. I've been doing that for 28 years. So I'm board certified in psychiatric and geriatric dementia nursing. And I'm retired from the Army where I started my nursing career. Did 23 years, went to Desert Storm, saw good psych stuff. And then I just last year retired from the VA, where I was the dementia care coordinator at Palo Alto VA. And I now live out here at New Mexico in Albuquerque. So looking forward to setting up a practice here. But I've been teaching with WISR since about 2017, and I love it. So hopefully you guys will get something out of this. This was something I had suggested as a topic because I think it's important for us to know, about this stuff, even though we're not doctors. I mean, doctors as far as medical, like some of us like me, we have our doctorates and everything. I have an EDD in counseling psychology. So why would we want to know about any of this? Anybody got any ideas outside of reading the slide? Anybody want to share why you were interested in this?
Hi, my name is Lori. I monitor my patients. I monitor my clients when I know what they're taking and I know how much, and just to check in. And if I see something going on with them that's different, especially my adolescents, I have to check into what's going on. What do we need to change? You got to call your psychiatrist. It's just another part for me. It's another part of monitoring and being a part of the therapeutic process.
Sure. Thank you for sharing, Lori. That's very important. Yes, very true. And it warms my heart when people want to learn about the meds their patients are on. It does. It really does. Because as a psych nurse, I've seen so many things go downhill on patients not being monitored and stuff like that. So anybody else want to share?
For me, this is Julie Cousin. I'm a licensed therapist. For me, I just really want to get a better understanding of the side effects, because often my clients they have a med regimen and they're experiencing certain side effects, and it actually maybe increases the symptoms that they're presenting with concerning, as they're working with me. So it's helpful for me to, gain some knowledge concerning all of the side effects.
Excellent. Yes. Very good. Thank you. So I did a little digging. In the CDC, the go-to place, had some statistics, and I thought I would share at least one with you. So as of 2016, so that was only 4 years ago, 56.8 million people went to a doctor's office with some kind of a behavioral or mental health issue. Also about 4.8 million ended up in the ER, which is like the go-to place when you're in crisis, which is not a good thing. But so chances are, if you're seeing clients, whether it's inpatient or outpatient, you're going to see somebody who's going to be on some kind of medication, and it's going to be a psychotropic medication. So yes, that's why it's important for us as therapists to know, therapists, counselors, social workers, any capacity you're in that has to do with mental health. And chances are, has anybody already been asked? Have you already been asked by clients questions about your medications, or have they come in and said things about their medications like, I don't want to be on it, or something like that? Anybody had that experience yet? Well, I know I have. Even as a nurse, of course, obviously, but even as a therapist, I have. So that was why, I wanted to make sure that we had this and talked about all this stuff. Now, part 2, I'm going to focus on addictions. I think next month, So right now we're going to cover mostly the basic psychotropics, okay? So I just have a few objectives for the class. It's basically, I want you to be able to name things and recognize things when you see them. One of the problems we have when we're working with medications with psychiatric patients or clients, you know, that are coming to see us, is that we don't often know or are able to recognize what the name of the medication is, what it's for. We see somebody with side effects come in, or they're asking about side effects, because there are some side effects that do cause people to not comply with medications, which is a problem. So that's what happens. So that's why, okay? Then we'll learn about some side effects. I'm going to give you a little bit of neurobiology. I think it's important that anybody, not just the physicians, know a little bit about what it is that the medicine, you know, does in the brain. I started teaching families about dementia a couple years ago, and it really helped the family members to know the neurobiology, you know, and being from a medical background, it's one of my things to teach what the brain is doing with, especially with mental illness and all. So I'll try not to make it too complicated. Feel free to ask questions as we go along the way. Okay, I'll try not to lose you. Okay, so start off, medication classes. In psychotropic medications, we basically operate from 6 basic classes, the main classes. All the medications you see there out in the world come under these classes of medication. So I want to make sure that you know that there are these classes. If some, you know, if you're asked like a class of medication, especially on your exams. So we have what are called anxiolytics, which are, from the name, you can see what, anybody want to guess what they're for?
Anxiety.
Exactly, yeah. Some of these you can tell from the names. Antidepressants, and there are different types. The ones we use the most now are the SSRIs, and in some cases the SNRIs. And I'll go through those. The MAOs and the TCAs, they're older, and there are more risk with them, but some people somehow in their lives have been on them and they work, so we don't mess with them, but they are older. We have our mood stabilizers, which are for our bipolar disorders mostly. Okay, and you'll see those. Antipsychotics. And believe it or not, people in private practice or people that are not working in a hospital, you will have clients come to your office who are on an antipsychotic and they just happen to be managing. Anybody have that situation with any of your clients, that you have one that is actually on antipsychotics?
Yes.
Okay, so you know. And then also, sometimes a certain antipsychotic like Abilify, and you've seen this on TV, they are used to augment an antidepressant because some depression can manifest psychotic disorders. So it's important that we know how they're used with those, because we want to look out for the side effects of those too. And then we have, what's that?
What other diagnosis would constitute giving an antipsychotic?
A mood disorder.
No, you mean a antipsychotic with a mood disorder?
No, I'm just wondering what other diagnosis would constitute a psychiatrist giving an antipsychotic.
Well, we've got, of course, the obvious schizophrenia. We've got delusional disorders. We've got, there are like bipolar mania, where there could be psychotic features. There is in the DSM, there are a couple diagnoses, one especially major depression with psychotic features. And so that's when we start looking at, okay, is there maybe an affective disorder like bipolar, which means you have, affective disorder where you have a mood disorder and a psychotic disorder. So it crosses that line. So those are some of the things outside of the usual psychotic disorders like schizophrenia, bipolar, and delusional disorder. How many of you are familiar with the DSM? Are you using the DSM-5? If you don't have one, I would highly recommend having one. They do have a mobile app. The DSM-5 does have a mobile app, and it also has a differential diagnosis app. If you like apps like I do, but it's a very useful guide to have when you're looking at this kind of thing as to why somebody would be on a certain med. Did that answer your question?
Yes, thank you.
Okay, no problem, no problem. Sedatives, hypnotics, these are the sleep medications, and some of the other ones that we use in crisis management. And like I said, detox, on part 2, I want to get deeper into detox with addictions and stuff, so that's why I made that its own separate thing. We'll look at others. So these are the main classes.
Karen, I have a quick question. I think I struggle with, you might be getting into this later on in the seminar, but the generic name versus the brand names.
Yes. Okay.
So that for me is like, you know, people are telling me the generic name because I think they use the generics more often these days. And I'm like, I have no idea. I feel incompetent. So
yeah, no, I know. Actually, anytime I talk about a medication, chances are you're going to see 2 names.
yeah, okay.
So I will say the generic name and then the brand name. And a good way to practice too is when you're watching TV, if you see commercials that are for these medications, look at the actual name of the medication that's in small print.
Okay.
And you'll see that you'll recognize some of these medications, like, you know, Chantix. If you look below, it says Wellbutrin hydrochloride. Well, Wellbutrin's an antidepressant. So I always have fun with that, but that's kind of a fun exercise you can do. Okay. So I'll try and get you through this. If I don't mention both names, ask me, and I'll try to remember what it is because there's a lot. I tell people when I teach nurses, if they wanted us to know everything, they wouldn't have given us drug references.
Oh, okay. Do the drug references have both generic? Is that something I could purchase and be able to have both?
Yes, they do. And I actually put it in one of the references. It's the Clinical Handbook of Psychotropic Drugs, and it's a wonderful book put out by Hogreef. And there's a print version, an online version, and then like an interactive online version.
Oh, perfect. Okay. Thank
Well
you.
worth it. They're a German company, but yeah. So I have that in the list of resources for you, and I can also send you things afterwards. When you mail me your information, let me know in your email if you want to have extra resources, because I have a ton.
Oh, yeah. Absolutely.
Yeah, and you know, like in nursing, we have in psychiatry, we have the drug references that cover all drugs, but psychotropic drugs are so unique and so individual that there is a whole separate drug reference just for those.
Oh, wow. Okay.
Yeah, that's how important it is. Okay. All right. Did that answer your question?
Yeah, perfect. Thank you.
Okay, great. You're welcome. So this is your brain. Supposedly. All right. Just imagine your brain. Okay. I just wanted to illustrate just how intricate the brain is when it comes to our moods, our cognition, our behaviors. We have certain hormones that you probably have heard about. Serotonin, I know everybody's heard about that. It's like the go word. But we also have dopamine and norepinephrine. These are 3 of the main hormones that activate or that are implicated in our moods. And when they're balanced, we're okay. It's the imbalance that causes us problems. So this is a Venn diagram, and you can see how the 3 circles there, they interlock, and then there's one in the middle where we have total balance. So let's look at the ones on the bigger part where it actually says what the hormone is for. So let's start on the right with serotonin, since that's the most common one we hear. So when serotonin is doing what it's supposed to, basically our moods are stable. And we think, okay, you know, we don't go around punching people when we're upset. And we can manage stress. Our memory's okay. All right. So that's what serotonin does. So when there's not a balance, what do you think happens? We start to have problems. Right. And so if you have somebody that's got a major depressive disorder or is having a serotonin imbalance and, you know, bipolar or something, these are some of the things that you've seen, and this is part of the reason why this is happening. So when somebody says, yes, it's a chemical thing, it really is a chemical thing. You know, quite ironically, when people, you know, they tend to say it's in your head. Well, yeah, it is in your head. It's in your brain. Okay, so we want to remember there's a chemical component to this. And your clients will actually, you will find that there may be improved compliance or there may be more satisfaction with their care if they actually have some of this knowledge to drive their own care, there tends to be more compliance with knowledge. So that's serotonin. Let's go to the left to norepinephrine. Okay, have you all heard of norepinephrine before?
Yes.
Like epinephrine. So this is like your energy hormone. So when it's in balance, you've got the energy, and this is where you are able to go out and socialize. You know, people with social phobias probably have an imbalance in this, and you're alert and things like that. Okay. So when there's an imbalance, some of the actual diagnoses you'll see are OCD, ADHD, the inattention that we have in some cases, and you can see depression because of lack of energy. Okay. So why do you think ADHD and OCD would be a result of norepinephrine imbalance? You see in the list there, it says concentration and alertness. Yeah, concentration twice. See, I thought that was important. Typo. Okay. So that's norepinephrine. So let's go to top to dopamine. Now you've probably heard the first part of this word, dope. What does it remind you of? The obvious?
Drugs.
Dope, yeah. Or when somebody says that's dope, you know, that means that's good. Well, look what the first word is there when it's in balance, pleasure. This is your pleasure center. All right. Dopamine helps your brain to close those gates to pain, so that, you know, some people that say they have a high pain tolerance, their dopamine levels are probably high, right? So it gives you that motivation. But if there's an imbalance, guess what happens? You need more and more of that pleasure to be satisfied. So that's what happens. So dopamine, when it's imbalanced, that's what happens. Okay, so we have the hormones by themselves, serotonin, norepinephrine, and dopamine. Now let's look how they're supposed to interact with each other, because they are in the same space together. All right, so let's look at the serotonin dopamine, which is on the right where the green and the yellow intersect. So when these are in balance, basically because of how they operate on their own, you'll get satisfaction with life. You'll get that in, you know, that ability to control your impulses, whether it's with aggression or maybe impulsive behaviors like with mania. Also, which is a big thing with some people, with a lot of people, is your sexual function will be okay when they're in balance. And one of the problems we have with our clients is, especially if they're on certain medications that affect that, is sexual function. And one of the resources I put down for you is actually a book called Psychopharmacology, and it talks solely about this phenomenon. And I've found in my career, mostly as a nurse and then, you know, recently as a therapist, but I've found that one of the biggest things, especially in men who were on certain medications, was they didn't want to take them because they couldn't function and they were young men, you know. So that was a big thing, especially in addictions. So let's say you have an imbalance in there and the dopamine and serotonin aren't getting along and they're having a feud or something. They're not getting along. So there's an imbalance. So if balance means impulse control, normal sex response, satisfaction of life, what do you think imbalance means?
Dysfunction.
Yeah, total dysfunction in some cases, yes.
Chaos, drama.
Yeah,
Mood
drama. I like that, chaos. Yeah, anxiety.
Right.
This is where, you know, instead of,
Aggressiveness.
what's that?
Aggressiveness.
Aggressiveness, yes. Instead of counting to 10, you don't even count. Okay, this is where people get into big trouble with aggressiveness, okay? So on the dopamine serotonin side, that's why we want that balance, because of what they do when they're in balance. It's a good thing, okay? Any questions so far? Okay, hearing none, let's move down to the bottom where serotonin and norepinephrine interact. Okay, so when these two are in balance, when they're getting along and happy, you'll have a normal sex response once again, because of one deals with energy, one deals with mood and relaxation, okay, satisfaction with things that you do. You know, a sense of pride, not in a bad way, but a sense of pride in what you do. and you know, you kind of enjoy life because you have the energy and everything. And also, one thing that we learn about something that happens from childhood on, you know, when you're babies, is this ability to self-soothe. And people that are older who aren't able to self-soothe, chances are this came from, you know, a long time ago, but their levels were not nurtured. So self-soothing is a way of impulse control. So if norepinephrine and serotonin are not getting along at one point, you see some of these imbalance symptoms. Do they look familiar? Did we just talk about some of them? I see some that look familiar. Anxiety, irritability, aggressiveness. Overeating, yes. Why do you think overeating would result from an imbalance between the norepinephrine and serotonin? Think about what the two do. Does anybody work with eating disorders?
You're just not paying attention. You know what I mean? You're just,
okay.
You're not, yeah.
Well, I think there's at least from personal experience, when my medication is not in balance, there's a tendency, I never got the fact that it comes from that. The overeating is, well, there's less joy, there's less, I'm more impulsive. I'm more impulsive, and I'm looking for something to fill me up because I'm not being filled up, you know, normally in life.
Okay, excellent. Thank you for sharing that. Yeah. Look on the norepinephrine side. What do you see down in the red? What is one of the diagnoses there? Which happens to be a hallmark of eating disorders.
Depression.
Impulse control.
OCD. Obsessive compulsive disorder. We find that people who have eating disorders, part of that comes from the need to control something. And when your life is out of control, the only thing you control is your eating. And so what happens?
You become anal about your eating, either not eating, or overeating.
Right. Anal is the same as OCD. OCD is the actual diagnosis for anal. So when the norepinephrine is acting up, there's your overeating or even your undereating for anorexics. Okay, that makes sense?
Oh, yeah.
Okay. Well, good. I'm glad you got something out of that chemically.
No, I learned something that I didn't recognize before.
Oh, well, good, good. Well, hopefully we can put some more information in there for you. Okay, well, let's move over to the upper left now. We've got the norepinephrine and dopamine deciding if they want to get along. So if they're getting along and they're in balance, this is where you get your motivation, your concentration, attention, because that's what they both do, right? Individually, and when they work together, it's even better because they enhance each other or they complement each other. But when they're not talking to each other, this is where you get your ADHD, impulsive talking. It's, you know, specifically talking. It's just jabber, 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 you know, somebody who can't stop and they want to stop. That's the difference. There's a difference between someone who talks a lot and doesn't want to stop, and somebody who gets disturbed by not being able to stop. There's a difference. So these is where you get these things, okay? So as you can see, by themselves, there's a risk of imbalance. Together with another one, there's a risk. So our goal is, if you look right smack in the middle, there's a happy face. That is our goal with medications, with therapy, with supporting our clients, with being able to collaborate with their prescribing physicians, of course, with their consent, hopefully, because that is all-inclusive care, and that makes it easier for us to be able to help our clients when things are happening and they're on meds. So the middle piece is a must. We have to have balance. When there's imbalance, then you get your mood instability, you get your delusional stuff, you get your confusion, behavior, impulse control, all these bad things happen. And so hopefully what you're seeing after I've explained this is that happy face. If that happy face is not there, then something is happening in the brain and the body that's causing it to go off in different directions. And so these things that I'm showing you are the reason why. right? So hopefully this, I thought it was a simple diagram. I hope it is, because I got some that are worse. Helped you understand. Anybody have any questions on this or anything that you didn't understand that you want me to answer?
I just want to mention the word unmanageability comes to mind when these are not in balance.
Yes, exactly.
Feeling overwhelmed and knowing this, after so many years, being able to deal with it, but not knowing it as somebody new at this, everything feels overwhelming. Life becomes unmanageable because you don't know what's going on, what's happening in my brain.
Exactly. Thank you. And this is one of the things that is missing from a lot of our, patient education in the world is, like, even when I was working as a nurse inpatient, the pharmacist would come and do discharge instructions, and they wouldn't say much about the meds except take it this, watch for side effects and all that. But nobody really taught the individual why this works the way it does.
The education.
So, education is like important. It's a must.
It is so lacking. I worked in the treatment field for many years, for 18 years, and watched these psychiatrists that came in, and there was always the education about medication was not being done. So people had no idea, they didn't know what they were taking, why they were taking it, and that caused a lot of incompliance.
Yes, exactly. I remember working in when I was with the VA, I spent some time as the nurse for the addiction clinic. And back then, one of the medications that we used, I don't know if it's used anymore, antabuse. Have you heard of antabuse?
Yeah.
Well, no, someone forgot to tell these guys that you can't use vinegar if you're on antabuse. You can't have ketchup, anything with vinegar in it.
Oh.
It interacts with it negatively. Yeah, surprise. Antabuse, you can't use anything with vinegar. And nobody knew that. I mean, people didn't read labels, they didn't know that ketchup has vinegar in it. So these guys were all like on antabuse, and they would have their fries and whatever, and it wasn't working, and they'd end up relapsing.
Oh my goodness.
So,
Yeah. My years.
Yeah, so now you know. Okay. Yeah. So what I want to do is I'm going to show you something else, and this is just so you can have like a real visual, because this is a Venn diagram, but this is actually what's going on in the brain. This is called a synapse. These are called the receptors that are working in the brain, where these hormones are going back and forth, back and forth. And so this is what it looks like in the nerve centers, the neurotransmitters. So you see at the top, there's one end that's sending everything. So it's got these places that hold on to the serotonin. What's that? And so what it does is when our hormones need to be working, what happens is this top part of the neurotransmitter sends what it needs out. So it's a transmitting neuron, and it's got these little things called vesicles, and so the serotonin's in there. When there's a need, it sends serotonin into this open space, which is called a synapse. So when our nerves in our brain are firing and talking to each other, what they're sending across, not just these three, but other hormones that work in our body like cortisol and all those, they're sending them across a space, which is called a synapse. So if you think of like if you've traveled and you leave the boarding area and you go down the gangway to the plane, that gangway is like a synapse. Does that make sense? I have the strangest analogies coming. But I always think of that as a synapse. So they're sending us, we're the little the hormones and the neurotransmitters, and they're sending us from the boarding area to the plane, which is the brain. And so we go down a little synapse, okay? So whatever's in the synapse is going to be taken up by the thing on the bottom, which is the receiving neuron. So that's the other half of this pair. And you see the little knots that are, there's like 5 of them that are at the edge of this. You see how they're receiving the serotonin. Okay, so what happens is it takes what it needs, but it can only take so much to be in balance. So what happens is it sends it back up, and that's where you get your reuptake. So when you hear things like SSRIs, selective serotonin reuptake inhibitors, it's selecting certain serotonin that is not needed, and it causes, when it takes a certain serotonin if it's needed more, and it blocks the upper half from taking it back. Okay, is that clear as mud yet? Because I'm going to show you a video.
So in the medication, let's just say Effexor, in the
Mhm.
medication, does that include the three different, the norepinephrine, the dopamine, and the serotonin? Does a medication include all three of those?
The medication will be acting on those three. Those three are already present in the brain.
Okay.
So the medication is made up to interact with those a certain way.
Right, but isn't it replacing some of the chemicals that are not, that your brain is asking for? I need this now, whatever it is.
It can, yeah, it can. I see what you're saying. It can, yeah. So what this is talking about, in addition to that, is these things are in your brain already, but if there's not enough for your brain to function because of chemical reasons, or if there's too much, like mania,
Right.
then those medications that we give them either cut down on, cause those to not be so much, or cause more to be put in the synapse for reception.
Okay, so that's why some medications work, some medications don't, depending on what
Yes.
you need in your brain and what you don't need, and what the medication has to offer.
Yes, exactly. Mhm. Okay,
I have a question, sorry.
sure.
So this is kind of like a nature versus nurture kind of question. Can we just naturally, like some people have just naturally have a lower baseline compared to others in terms of like all these chemicals in the brain?
Some can. I mean, you talk about manic depression or bipolar disorder, that's hereditary. So some people are just born with these levels. Depression can be, hereditary. Schizophrenia, definitely hereditary. So yes, there is absolutely people who are born with these certain things going on that they will automatically, as they get older, need. I mean, there are children that are diagnosed with bipolar disorder as children.
So then with the environment in which, people grow up in impact the expression of the disorder, I guess.
It can. Go ahead.
Like, I guess maybe if they do carry it, what if I'm just kind of wondering if if you provide like the right and healthy environment, that maybe it would never be expressed.
That could happen. I mean, nurture is very important. I've always, and I know a lot of scientists these days have always thought of the two as complementary, not one more than the other. There are studies. In fact, there's an author named Wally Lamb, and he wrote a book. I forgot the name of the book, but it was basically, and there are actual studies that have been done on twins who were identical twins, but they were raised apart just because of circumstances, and one developed the symptoms and one didn't. And when they looked at what was behind that, part of it was their environment. Was their environment nurturing to not have to worry about the symptoms? And if the symptoms showed up, were they managed right away, or things like that? If something's going to show up that's pretty much hereditary, it's going to show up. But yeah, nurture and environment, and how the parenting is done and all that is very important in some of these to help them not be so unmanageable or not be so destructive to the individual, especially if they're young.
Is the book, I Know This Much Is True?
I think so. Yeah. The twin brothers.
Yes.
Yeah.
Yes.
Mm-hmm. Yeah. And then some of these studies are interesting, having identical twins and then they grow up separately and one develops schizophrenia, the other one doesn't. So there's a whole neuroscience to that stuff. It's just fascinating. I highly encourage you guys, if you're interested in stuff like this, is to look at some of these neuroscience studies that they've done and these things like that. It's really fascinating.
Also, someone asked in the chat how much are these disorders are related to the gut microbiome.
Oh, yeah. There's a lot of information coming out about that. Well, there's an biofeedback. Years ago, I remember doing some biofeedback because I have irritable bowel syndrome, and anytime I'm stressed, it acts up. And I remember doing biofeedback, and I was actually told that I was a gut responder to stress. So yes, there are things in the gut that are activated when we are under certain conditions. It's the mind-body connection, the mind-gut connection. So that's why, you know, talking about a lot of these biomes and the biotics, you know, the probiotics and things, a lot of people take probiotics because they help with the flora in the gut and the hormones in the gut. So these hormones, you know, that are in the brain, stuff travels throughout the body, and so, you know, everything gets in the bloodstream. But yeah, there is a connection with stress and the gut and how we manage things like that. Now, if there's something like schizophrenia or psychosis or something like that, you're pretty sure to know that the gut will be the stress part, but the symptoms itself, the psychosis and the mood and all that, will be up where the brain is, where the chemicals are. But did I answer that question for that person?
Yes, thank you.
Okay, thank you. Yeah, I'm not a nutritionist, so I'm still learning about some of this stuff. Yeah, but probiotics are a big thing. Okay, let's watch this video that I got, okay? Okay, I'm gonna share this video with you. It's actually talking about neurotransmitters, okay?
Epinephrine modify the rest of the brain. Just like a dimmer switch can control how light or dark a whole room is just from one small area, each cell has connections with 500,000 other cells, and you only have 250,000 in your whole brain. The signal comes down the nerve, it releases these chemicals, which then go across the space called the synapse. Once those chemicals fill up the receptors on the left side of the synapse, the signal is sent. That's how the nerve on the right influences the nerve on the left. Here's a higher magnification of the same thing. The signal comes down the nerve, it releases, goes across, reaches critical mass, now sucks back up into the yellow vacuum system. Now the body will recycle some of it, but the rest of it is destroyed and thrown away. And how much is destroyed and thrown away is dependent upon your family characteristics. So if you don't have enough of the chemical to fill up those receptors, then you will have the signs and symptoms of depression and anxiety. Some people have problems with too much rather than too little. This is what we think happens with people with schizophrenia, and this is the dopamine system. They're being so overstimulated with dopamine, they become very agitated, they hallucinate, they can't sleep, they hear voices. So what we use is medications called atypical antipsychotics, which are represented by these green balls, which temporarily sit and block those receptors from being overstimulated. Helps to calm them down, the voices go away, they can sleep much better if they'll take their medication. Now this is what happens with depression. Chemical is released, it did not reach critical mass, so sucks back up into the yellow vacuum system, and a double dose is not released. There's enough to fill up those receptors, and when the signal is sent, now suck back up into the vacuum system again, waiting for the next signal. Now, antidepressants are not addicting. All they are these white balls that simply plug up that vacuum system. So now the body can't bring it back in and throw it away. So it helps your body conserve what you've already made. So now the concentration in that gap increases. It's like having instant hot water. When you turn on the spigot, you have hot water immediately. You don't have to wait for all the cold water to be pushed out of the hot water pipes before you get a cup of coffee or tea. This is what's addicting. This is in the pleasure center of the brain, and these are the dopamine receptors. And these purple balls represent methamphetamine and cocaine, which now begin to hit and to smash and to destroy those receptors. And it's like taking a hammer and smashing it through a board of wood so that people can no longer experience normal pleasure and joy in life unless you have more and more cocaine. So if you understand that, you understand how the brain works.
Okay. All right, what'd you think of that?
Wow.
Wow, I've never seen it put like that. It makes so much sense.
Yeah, out of this thing here. Okay, so did that make sense? Did that help with your understanding?
It makes it clearer.
Okay, good.
Mhm.
Yeah. Well, I thought you'd like that. Sometimes you just got to see it, you know? But yeah, that's so like I'll probably show that one again because of the addiction part we'll talk about next time. All right, so let's start with one of the most obvious ones and the one that's probably the most common because it's not always necessarily a function of an actual psychiatric diagnosis. It's anxiety, right? Can anybody truthfully say or want to admit that you never feel anxiety in your life? Thought so. If I had a teacher that would tell me the only time you don't feel stress or anxiety is when you're dead, which makes sense. You think about it. Otherwise, it's all stress and anxiety. Sometimes it's okay, sometimes not so much. It depends how we manage it. So we talk about these kind of meds that are called anxiolytics. So this is that first class of drugs I mentioned, anxiolytics. They come in two classes. So we have what's called benzodiazepines, and then we have some that are called non-benzodiazepines. The one that you're probably used to seeing are the benzodiazepines, like people who are on Ativan, lorazepam, which is Ativan, alprazolam, which is Xanax, Klonopin, which is, clonazepam, which is Klonopin. So the azepams are the end part of these words. So if you see a medication with that part on the end, azepam, it's going to be an anxiety drug. The difference between the two subclasses of this class are the benzodiazepines are narcotics. The non-benzos, which there are not many of them, are the non-narcotics. And so we want to remember that, because I've seen some people refer to all anxiety medications as addictive, and some of them are actually not addictive, and that would be a disservice to your client if you thought they were all addictive and then you advocated to not have them on them when they could be benefit.
Would you consider
what's that?
Would you consider buspirone one of the non-benzodiazepines?
That is exactly one of them, and yes, and I'm going to cover that in the non-benzos, so thank you for bringing that up. So I'll talk first about the benzos, because that's what's used more, and that's what people tend to get addicted to, which makes life really horrible, especially if they come off them. So these are what we use in crisis management. So like if you work inpatient or in the ER or something like that, you'll see these used the most because of the level of acuity for the patients. But there are also people who are on it. Does everybody know what PRN means?
Yes, as needed.
Basically, as needed, yes. So it's from the Latin, per something. But that's why people would be on these medications on an outpatient basis, to kind of augment whatever medication they're on if they do get over anxious. So they'll be on things like the lorazepam, which is Ativan, the alprazolam, which is Xanax. Some people are on PRN, clonazepam, which is Klonopin, and there are others, but these are like the main ones. So these are used for things like anxiety disorders, panic especially, panic disorders, phobias, because when a person is exposed to something they've got a phobia about, it can really increase their anxiety levels. So taking one of these medications takes the edge off, basically.
Is that supposed to be panic DP or DO?
Oh, I'm sorry. Thank you.
Oh, okay. I just wasn't, maybe it was something I didn't know.
How about this? Panic dysphoria. Would that work for you?
Okay.
Panic displeasure. We just made a new word, panic displeasure. It worked. I'm writing the new dictionary. How's that? So yeah, that's the first class. But again, it's important that we can differentiate so that we don't make that mistake. But the main differences are one is narcotic, one's not. Okay. So I listed these now with a little legend here. So B means a benzo. That's a narcotic one. Non-benzo is the one with just NB. Okay. So for the sake of, I think, was it Mary Beth that asked her the question? Sounded like the voice. As far as the names, I've put the generic names and the common names. So hopefully this helps. So you'll see lorazepam, which is Ativan. You'll see Xanax, quetiapine, Seroquel. Okay, we use that. We use it a lot with dementia because of the agitation, so they can quell. If you look at quetiapine, it almost looks like somebody misspelled quiet. When I was learning about medications, one of the things that I was taught is look at the word. look at the root words, because you'll find that you can find the clue to what this is. So Seroquel, well, what do we know about the word quell? What does that mean? What does it mean to quell something? Quell something.
To stop it?
Yeah, basically to calm it down. Quell, when you quell something, it's quelling. So when you think about that, okay, quetiapine is an anxiety medication we use that will help calm somebody down, but it's not a narcotic, so it's not addictive. WISDRAWAL is a little older drug. I haven't seen it used a lot, hydroxyzine, but it's another non-benzo that is great for calming people down. We use it, I have used it with addictions, and believe it or not, if somebody is having like an adverse reaction, like they're getting the itchies or something, it actually helps with that, like with the skin itchies. And then we have Valium, which is an older drug. And those of us from the 50s and 60s may have heard the term mommy's little helper. Back in those days, a lot of women, housewives, were given Valium by their doctors because they were all stressed out. And they would actually give it to their kids when the kids started acting up. So they called it mommy's little helper, and highly addictive. But that was like the drug of that time. And then we have the Boost Bar. Somebody mentioned Boost Bar. So that is a non-benzo. Okay, Inderal, propranolol. You'll notice that some of these drugs sound like drugs that are used for other medical conditions. And that happens in the pharmacology world, as there'll be these medications that were originally made for one thing, but they've had what's called serendipitous effects on another thing, or they found these unknown like benefits. So they use them, they give them kind of like off-label permission, things like that. Somebody mentioned Effexor, venlafaxine. And again, when you watch TV and you see these commercials, look underneath the name of the popular name that they're advertising. You're going to see some of these. You'll see venlafaxine. You'll see some of these, okay? One medication that is a non-benzo, but it is an antipsychotic that we use in crisis management is Haldol. Especially on an inpatient or an emergency setting. If someone gets what's called a cocktail because they're just totally like bonkers, it'll be a mix of about 5 milligrams of Haldol, about 2 milligrams of Ativan, and then we'll throw in either 50 milligrams of Benadryl or 1 milligram of Cogentin, which is an older drug for to manage the side effects of these. And this is liquid, and we give it in an injection. So that'd be the only time that Haldol would be used for an anxiety thing, okay? So you shouldn't have an outpatient person taking Haldol unless they've got schizophrenia. So again, this is a list of the main medications that are either benzo or non-benzos. Benzos are the anxiolytics that can be used long-term. So we heard a mention of Boost Bar. Boost Bar is probably the most used non-benzo. And the way it's used is if somebody is, let's say they're inpatient or they've been started for anxiety disorder or severe anxiety, and they've been on Ativan, let's say on an acute setting or something, and they're getting ready to be discharged, but they have a diagnosis of an anxiety disorder. So one of the things that the psychiatrist will do is start to transition them so that they don't discharge them on a benzo, which is actually can be illegal because it is addicting. But they'll start them on a dose of Boost Bar, and as they are on the Boost Bar longer before they're discharged, they'll start to taper off the Ativan or the Xanax or whatever else they're on, so that by the time they're discharged and go home, they should be on a regular level of Boost Bar, and then they can be discharged with maybe a PRN prescription for the Ativan or the Xanax or whatever, in case they have breakthrough anxiety, but the Boost Bar would be what they're on. So yes, there are anxiety medications that you don't have to worry about addiction with. So I was talking about the two classes. Again, benzodiazepines, anxiety, severe anxiety. It's rapid release. It reacts quickly. It's got a, it wears off in about 3 to 4 hours. Okay, so that's why we use it on a crisis management, because it can be addictive. So again, like I was saying, it can be a booster. it can augment other medications for that breakthrough. We call it breakthrough anxiety, kind of like when you have somebody who's got like pain issues and they're on a pain medication that's pretty strong, but they may have breakthrough pain. So we would give them like a Tylenol in between or a Motrin in between their doses, because you can only take them a certain amount of time. The thing about the timing of medications, any medications, is there's a certain level that builds up in the bloodstream, and there's a half-life, which is the amount of time it takes for half the drug's effects to go, like be eliminated, through the kidneys or whatever. So then that's why you get the constant dosing. So there's always a therapeutic level because of the half-life. That's why if you've ever seen something like stat, like, Ativan stat, like in ER or something. So if something is stat, it means it's going to be given right away, and it's going to act fast. If you give somebody Haldol and Ativan and something else stat, they're going to go down right away. They're going to go to sleep. They will be out. Are you with me on the slide? Everything okay?
Yes.
Okay. So that's why we call them boosters. Again, with the half-life, a lot of people, they're not biologists, they're not, scientists or psychiatrists, med school and all that. So sometimes we want, we say, what do I have to know about half-life for, something like that. But again, like going back to the very first slide, even if you don't do this stuff as a profession, like, prescribe things, you're still going to have people that come in that are experiencing issues from their meds. And you're going to know that it could be the half-life, it could be the dose or something, which is why it's very important to build that rapport with not just your client, but hopefully they give you consent to talk to a prescribing physician if they've got one. These are some of the side effects. So somebody that's on benzos, has anybody want to share if you've seen somebody on benzos, either inpatient or maybe outpatient, where some of these things you saw? Like I said, here's a big one here. It's a low risk, but it can happen. This is one big thing here. This is why when they give medications, there's always a warning. It says, do not operate machinery or drive. And if you do, you can actually get a ticket for a DUI because it is sedating. It's a sedative. That's what they're called. So if you think about it, and then with older people, they don't clear meds as fast. So it builds up and they become even more of a risk, especially for falls. But if you're somebody young and you pop a Valium or an Ativan or something while you're driving because you're stressed about traffic, you're going to have an accident. So these are just some of the side effects. I always tell my clients, my patients, carry around some sugar-free candy or something, or gum, because you get cotton mouth. Here's one here I want to point out. Does anybody work with clients who are geriatric besides me? There are not many of us who specialize in geriatrics and dementia as therapists, but we're out there. But I've seen this on, the geriatric side is you give somebody Ativan, it's expected that Ativan being an anxiolytic is going to calm them down, right? Well, if it's somebody that can't handle it, especially an older person, because of the kidney clearance is not as optimal as a young person. Let's say you have somebody that was given a medication and you fully expected that they were going to calm down. And then maybe if you're inpatient or something, your nurse's aide comes and said, hey, Mr. So-and-so is climbing the walls. Well, yeah, I know I just gave him Ativan. Well, what happened was this phenomenon called a paradoxical reaction. It did the opposite of what it was supposed to. So if you have somebody that's on Ativan, or maybe if you are in a situation where you work with the doctor directly and maybe you prescribe, in some states, clinicians can prescribe. It's all this weird stuff, but I just want you to know this word paradoxical reaction, where somebody can have the opposite reaction of what this particular medication is supposed to do. And it happens the most commonly with Ativan, something about Ativan. So these are just some other side effects. Ataxia is where they just kind of they're not coordinated, they become clumsy. So again, you have fall risks. Now, I want to talk about just quickly withdrawal symptoms with anxiolytics, especially the benzos. Withdrawing from a benzo can be dangerous. I've actually known of a lady who was older and was admitted, and I forget if she had just stopped herself or if her doctor made the mistake and took her off her Klonopin. which is a benzo. Well, she started to withdraw, and you can actually have the kinds of withdrawals that sometimes will mimic alcohol withdrawal, like alcohol intoxication. And you can see the symptoms here. Some of them look like withdrawal from substances, but she actually, her cardiac system was involved, and she actually ended up having a heart attack. So the withdrawal from these is very important. If you've got somebody that you're working with who is taking anxiolytics that are the benzodiazepine type, and you're seeing them, and and you ask them about their medications, if they say that they stopped taking them suddenly or something like that because they didn't like them or they didn't want to be addicted, ask them if they've had any of these. Because the prudent therapist, I mean, we all know this, when you do your intake assessment, what is one of the things you're assessing? What is one of the inventories you're taking?
You want to know what meds they're on, if they're taking any.
Exactly. Mm-hmm. You're doing what we call a medication reconciliation, which is basically, yes, you want to know what they're on, how much they're on, when they take it. Are they still taking it? Are they taking it the right way? I mean, there's all these things that we as therapists tend I'm not generalizing, but I know people. So therapists tend to, again, get into that mindset of, well, I'm not a physician, so I don't need to know all this. I just need to know the names. But you really need to know a little more, if you're being prudent about things. And then there's these, again, because these are narcotic based, they become toxic, and guess what happens? Like I said, we had a lady that had a heart attack. People will overdose on these because they are addictive and they need more. You saw how that video was. They need more and more for that dopamine effect for the to get the anxiety down. They can overdose. First thing they do when they hit the ER is they get charcoaled. That's that the black stuff. So if I remember working on inpatient and we'd get a patient come up from the ER and their mouth was all black and then we know right away they overdosed because they give you the activated charcoal. It causes the person to throw up. So everything comes out, but they forget to clean them up. And so there's this black all over the place. So we always knew, oh, okay, but that's one of the ways we treat it. Okay. Or with Ativan and some of the benzos, it can actually depress the respiration. So you have to watch, are they breathing? Because they can have respiratory depression, or their blood pressure could bottom out because it is so sedating. So you want to be careful with these things. So if they have too much in their system, and again, if their system can't handle it, you're going to get these problems. Okay, so these are benzos. Let's go to the other ones, the nicer ones, the non-benzos. You notice the list is not as long. These are the safer ones, and these are used, again, long-term for social phobias. There are performers like Donny Osmond, Barbara Streisand are two that I know of for sure that admitted on TV that they have a severe social anxiety with performing. And before they go on stage, every time they were to give a concert, if you ever saw one of them in concert or performing on TV, you now know that they were taking a medication before they went on stage so they could perform because they needed that help. But that's what these medications are for. They're long-term, and so that's what they're used for. So that's a little secret. But a lot of celebrities, when they came out with their mental illness issues, it really kind of helped the community because it kind of normalized things, So again, non-narcotic. Okay. With these, they have side effects, not as severe. So most of the side effects are things that are more annoying. There are some that could happen, like the low heart rate, but there are medications for that which are not harmful. I wouldn't give it to somebody with asthma because it slows, it affects the breathing. Anything that is given for anxiety is going to affect the breathing because what is one of the things that happens when you get anxious besides your heart pounding? What do you start to do? Right? The thing about breathe into a paper bag. So it affects your breathing too. You start to overbreathe, and you can, if you're an asthmatic, a lot of asthmatics have their attacks from stress. When they get stressed enough and they start to hyperventilate, it activates that asthma. So if you have somebody that's got anxiety and they got asthma, you have to figure out a way to help them without having to put them on any kind of anxiety med. We're going to have to try something else or whatever, but sometimes they may need it. So you're going to have to monitor it closely. Have you heard of Raynaud's phenomenon? It's a circulation. If maybe some of you have experienced it, it's a naturally occurring thing in some people who their circulation is poor, so they're always cold in their extremities, like their toes and fingers are always cold. But this can, these kind of meds can also decrease some circulation that can lead to a side effect that mimics Raynaud's phenomenon. It's named after a guy named Raynaud. Okay, so just basically the main thing, the bottom line is, if you know someone's on these kind of meds, whether it's a benzo or a non-benzo, make sure that they know how to monitor it and make sure that you know what it is so that you know how to monitor it when you're with them. Or if they call you and ask a question, or let's say they end up in the ER, they overdosed, and you get this call and you're like, oh, I know what happened. Okay. Okay. Any questions on that? Anxiolytics. Again, this is an overview, so I'm not going to overload you. I'm going to give you the references so you can go do a deep dive. This is me wanting you to know that, hey, you're a therapist. Let's know about this stuff. Okay. All right. No questions. Let's move on to mood disorders. What are some of the mood disorders? What are we talking about when we say mood disorder?
Bipolar disorder,
Bipolar, yeah. What else?
depression,
Depression. Mm-hmm. Schizoaffective. Is that a mood disorder? Actually, it is, because it's got an affective piece to it, even though it says schizoaffective, because it's bipolar with, it's a psychotic disorder with a mood disorder, so we call them schizoaffective. So yeah. So let's talk about these. So remember I mentioned SSRI. That's the one that's used most commonly these days, but these are some of the ones that you've either seen on TV or you've heard about in both their names. So like I said, to somebody who asked earlier, you see I'm showing you both names of it so you know. Okay, so citalopram, Celexa, Zoloft is the most common SSRI. So you saw in the video that he was talking about how these one of the colors would block up the uptake so that the serotonin wouldn't be wasted. So that's what the selective serotonin reuptake inhibitors are doing. It's sending out, the medication is sending out those little balls that block the opening so that there's extra serotonin, which can be taken up on the other side to improve mood. So that's what we're talking about, SSRI. There's SNRIs, selective norepinephrine reuptake inhibitors, for the same reason. They're just used, different meds used for things that involve norepinephrine, ADD, things like that. So these are the most common medications used in the class for mood disorders. Again, sertraline, Zoloft is the most common. And Prozac is one that's used for OCD a lot, obsessive compulsive disorder. Paxil is one that we tend not to want to use with kids, especially. For some reason, Paxil, one of the side effects, they all have side effects, but one of the side effects that tended to be common was mania. It kind of triggered a mania. And I remember a friend of mine had gone to her psychiatrist and he put her on Paxil as an antidepressant, but she developed mania, and apparently the doctor was able to re-diagnose her correctly with bipolar disorder, because apparently she had that in her that it kind of manifested it, which was really interesting. There's lots of good research out there and literature on that. Mood stabilizers, okay, again, mood disorders, mood stabilizers, bipolar, mania, mixed episode. If you look in the DSM, you have bipolar disorder, it's got mixed, bipolar 1, bipolar 2, mixed mania, mixed depression. There's all these different kinds in the recipe, but it comes down to a mood instability. And you'll see that these mood stabilizers, they look like antipsychotics, don't they? But they come under mood stabilizer because they are used with some of these other medications as like augmenting. That's why olanzapine, Zyprexa, quetiapine, which is Seroquel, or aripiprazole, I think is Abilify. Risperidone is Risperidol. Okay, some of these. So that's why they're used as augmented, which is why I mentioned them here with mood stabilizers. Okay. The main mood stabilizers here are the Depakote, the lithium, Tegretol. Now, these medications specifically, they're neuroleptics. So these medications were originally developed as seizure medications, which is why one of the precautions that we have when we're looking at these medications is it lowers it does something called lowering the seizure threshold, which means if somebody's on these medications, they have to be monitored regularly because they could end up having seizures. And there's other things that could happen, but these Tegretol, lithium, Depakote, these also are seizure management. Lithium's the oldest one. It came out in the 40s. That was the first one, lithium, okay? So these are the ones that we use for mood stabilization, mood disorder. So some of the side effects, again, you see that dry mouth, okay? Some of these, they cause insomnia. So would you think somebody would want to be on them at night? So when do you think they would mostly be taking them? Let's say you have a client that is not sleeping well and they're on a mood stabilizer. And they said, I'm not sleeping well, I got insomnia. And you want to look at their medications, right? And see when they're taking it, and maybe ask them to talk to their doctor about possibly changing the time to the morning. So these are another reason why we want to know about these. The toxicity, something like lithium can actually shut down a kidney, and somebody ends up on dialysis, while they're treating this. I've had patients on the inpatient side that have had toxic. Unfortunately, one of them died. They were too toxic. Lithium, Depakote, Tegretol, these neuroleptics, they need to be monitored regularly. Usually it's like every 2 weeks, we'll have somebody get labs done to get the levels, because there's certain levels that we have to monitor for therapeutics. If these mood stabilizers, now with the ones Zoloft and the ones for depression like that, you don't have to monitor them, and there's no risk of overdose or addiction. They're regular medications. Mood stabilizers like these, if they are subtherapeutic on their blood levels, then they will continue to be manic. It won't be effective, okay? Then you're gonna have to they'll have to adjust the dose. And this is where you see your client comes in, they're on a mood stabilizer for bipolar, and they're still manic in your office, right? Well, the first thing light in your mind goes off is, well, maybe they need to have their dose looked at. Maybe when was the last time they had a lab? You could ask your client, when's the last time your doctor sent you to get blood drawn for your lithium or for your Depakote? If they say it's been months, then that's when you want to do some collaboration. Either, if you have permission to talk to their doctor, great, which I have in a couple of cases, or, you want to let them know, okay, what you need to do is go to your doctor and tell them that this is what your therapist noticed and, would like you to talk to him about. And you're fully within your scope, because you're not diagnosing, you're not prescribing. What you're doing is being an informed therapist and advocating for your client, your patient, and saying, hey, your labs might be off, and sure enough, you're probably going to find in the next visit that yes, the labs were off, because these have to be, monitored regularly. One of the things that I found in my work with dementia is, because they're in a long-term care facility, things tend to get left to they're here forever, so why do we have to check? Well, you don't want to kill them early, right? You want them to, if they're going to die of dementia, they're going to die of natural causes. They're not going to die of me letting them be toxic or subtherapeutic on this. Same thing with Depakote. Regular levels. If they're too much in the bloodstream, they can get toxic, and that's where you get those bad side effects where they end up on dialysis. With these kind of drugs, antipsychotics, neuroleptics, they can get what's called extrapyramidal, which is the EPS. You may have heard that term, where they get the shakes and the Parkinson's and the side effects. There are actually commercials on TV now that talk about that, EPS. Have you seen those? And they're advertising new medications that have come out to help with the EPS, the Parkinson's symptoms of certain medications. And, there's one of the lady that says, well, my doctor said it could be the medication I'm taking for my schizophrenia. Have you seen those? Anybody seen those? They're all over the place now. That's what they're talking about, the EPS. Okay? One of the compliance issues we have, the biggest compliance issue with mood stabilizers is the weight gain. It's part of something we call metabolic syndrome, where they can develop diabetes and things like that. But the worst thing is weight gain. Nobody wants to gain weight, especially if they don't have to. They will stop using this medication. And guess what? You're going to have a client come in that's just off the rails. And you ask them what happened. And you notice they're looking a little plump, maybe a couple of visits in. And they will probably be telling you, well, I was like putting on pounds and no matter what I did, I'm like, blah, you know, and so I didn't want to take them. So they stopped them, but they stopped them without talking to their doctor. So this is where you come in again as a therapist, advocating, informed therapist. Well, you know what? You need to talk to your doctor about that, because this is what happens if you come off this medication without your doctor helping you, is you're going to have these symptoms come back. They're going to be worse. Again, that's fully within what we do to tell them. We're educating them. That makes sense? Any questions on that?
When you were talking earlier, I think you jumped over the blurred vision, light sensitivity, and that is news to me. Can you talk about how profound that can be? I've never heard this before. Because
it has effects on certain body functions, like the dry mouth, the anticholinergic effect. When things dry out and you don't have the fluid in your eyes to kind of cushion things, then your eyes will become sensitive and you can get dry-eyed. We have this viscous fluid in our eyes that helps with our vision, not just the iris and the cornea and all that, but there's a fluid in there. And that's why with glaucoma, one of the things they check is the pressure. So when there's an imbalance in your eye fluids, then your vision is off. And you know, not just with the shape of your eyeball or something like that. So light sensitivity. So if a medication affects these kind of things and kind of dries things out or causes too much of these fluids, then it does affect your vision, because you're not able to see right through the fluids that are in there. Does that make sense?
Thank you. I'd never heard that before with this class of drug. Thank you.
Yeah, oh, no problem. No, a lot of people haven't, because we're really focused on things like dry mouth and insomnia. Blurred vision and light sensitivity is one of those ones that doesn't get talked about a lot, unless you're an eye doctor. Yeah, thank you for the question, though. Very good question. Any other questions? Okay, so again, I like to talk about overdose and toxicity, because it's important to know. You may never see it if you're doing outpatient in-office visits, but you never know. Like I said, there are some. Overdose and toxicity, again, it's hard to overdose when you're on an antidepressant, but people have been known to try. You just get very happy, I guess. I don't know. I've never seen somebody overdose on an SSRI. Mood stabilizers, again, if the levels. So if somebody's on a mood stabilizer, if you have like, let's say you have somebody new come in as a client and you're doing their initial assessment, you get to the medications and you find out, well, they're on Depakote or Depakine or valproic acid, 2 words for that. First thing, what is one of the first questions you want to ask them at that point? Anybody want to guess?
Last time they've had their labs checked?
That's a very important question. Yes. Anything else? Want to guess anything else you would ask them at that point?
How much they take and when they take it?
Yes. Mm-hmm. Yep. Yeah, thank you. Those are 2 of the main questions that you would ask right away. When's the last time you had your meds done? Your labs, and then again their dose and everything, and when they take it, because of this toxicity problem. And 9 times out of 10, when I'd be on the inpatient unit and I would see one of our patients who had bipolar disorder, and they've been there for a few days and they were still pretty manic, first thing the nurses would do is we go to the doctor and say, can we get a level? Sure enough, they'd be like subtherapeutic, and we'd adjust it and they'd be fine. So there are practicalities to knowing this too. Anybody know what nystagmus is? What is that? What am I doing? Cross-eyed. So if somebody manages to overdose on any of this, they can get cross-eyed. It's not permanent, but it can happen. So I'm talking about the mood stabilizer specifically in this one. When I talk about the labs, you want to know, like write it down somewhere, keep it on a sticky or something. These are the levels of these 3 medications, which are the therapeutic levels. If they're below this or above this, you're going to see symptoms or you're going to see problems. So this is something like when I was teaching nurses, I would tell them every time they're getting ready to take an exam, know your lithium levels, because they will always ask this. They didn't ask it on the MFT exam, but but I would highly recommend you write this down somewhere, get to know these numbers. If you have somebody that's on these and you happen to see labs, if their numbers are not between these numbers, then they're either toxic or they're subtherapeutic. And that's when you got to step in with education and advocating for them, for their doctor to look at this, okay? So that's what we're talking about with therapeutic levels. And it's just, this is a basic lab thing. It's a basic number thing. It's basically a memorization of these numbers. All right, any questions on mood disorders? You guys doing okay? Is it making sense? Am I blowing your mind, confusing you too much? What do you think?
Good information.
This is good.
Very helpful.
Well, I'm glad.
Good
I'm glad.
information.
Good. I'm glad to hear that. Let's move on to our favorite, psychotic disorders. This is the one you see on the streets a lot. When you look at people who are homeless, majority of them have a psychotic disorder and they're not able to stay on their meds, which is a vicious circle. If you got a psychotic disorder like schizophrenia, you're too paranoid to take your meds, so you don't take your meds, and you can't work because you get your schizophrenia, so you can't earn money to get your insurance. So it's like this thing that goes around, which is why they stay homeless, a lot of them. Are you all familiar with schizophrenia and the positive and negative symptoms? You remember learning this in the DSM? So basically that's what we're looking at, okay? I just took this out of the DSM and just from diagnosing. These require long-term treatment. So they're gonna be on these medications forever because again, this is, especially like schizophrenia, it's inherited. Are you all familiar with John Nash, the real subject of A Beautiful Mind? Remember that movie? Well, John Nash was the mathematician who got that Nobel Prize. Well, his son, John Nash Jr., you would think they were twins. Spitting image, not only of his dad, but spitting image psychologically, spitting image symptom-wise. They both had paranoid schizophrenia, exactly, math geniuses, but exactly the same kind of symptoms, okay? So this is one of those ones that they're gonna be on treatment for the rest of their lives. Like with thyroid disorders, you know, I have to take Synthroid till they put me in my grave. So if I wanna remain stable, okay? So these are just, you know, clinical presentations that we've all learned about. Are you familiar with the 4 A's, the positive symptoms? I mean, the negative symptoms, I'm positive and negative. So the anhedonia, A means against or without. So like an, okay? That means they don't have these, which is why they're called negative symptoms. It's because they're missing. These normal functions of personality are missing, so that's why they're called negative. So anhedonia, no pleasure. Alogia, their speech is affected. Avolition means they have no motivation. Asocial, they withdraw. So they're the people that kind of go around with this masked face and they're just kind of stiff and like that. You'll see them, okay? Does anybody have clients that you work with in any setting who have schizophrenia or a psychotic disorder that are on medications?
I have in the past in community mental health.
Yes, exactly. Okay. So you know what I'm talking about when I say these things. You won't, on the outpatient side, unless you're in community mental health, but if you're like in private practice or something like that, you probably aren't going to see many that have full-blown psychotic disorders that are on meds because those people are mostly in the system, I guess, in the system, okay? So let's talk about their meds. They're called, of course, antipsychotic, against psychosis, okay? What meds come to mind before I name them? Anybody want to guess what meds come to mind? Okay, these are medications like
Risperdal, Invega,
what's an old
Geodon.
one? Yeah, H begins with an H. What is that one?
There's Thorazine, Haldol.
Yes. Thorazine, yes. Thelazine, the zines. Those are old drugs, but believe it or not, there are some older people who are still on them because they worked.
Yeah.
Yeah. There is a side effect from those. We used to call it the Thorazine shuffle or the zine sisters because they had such profound effects, side effects. The main things that these are used for, of course, are the episodes of psychosis. They're also long-term maintenance to manage breakthrough symptoms, okay? So these are the ones that let that person with schizophrenia or a psychotic disorder be able to go function, be able to go to work, be able to socialize. So again, like these commercials that are all coming on TV now about these medications that they're on TV in the commercial, they'll call one thing, but if you look at the bottom, you're going to see they're an antipsychotic. And that's what's helping these people live with their symptoms. So that, because the baseline is they got voices. That's going to be their new baseline once they develop the disorder. What these medications is takes the baseline to a level of functioning where they have voices, but they're not as bad, or they're not getting the command hallucination telling them to hurt themselves or somebody else. So their baseline is voices, but they're not as bad. So that's what these medications are helping with. Really important, if you work with older people, we do not use these, or we should not be using these to treat dementia. They are not indicated for dementia. One of the things that I found working with dementia was when I would do medication reviews, or we'd have to do these like project improvement things, we had to make sure that the doctor, when they ordered an antipsychotic for one of our older patients, was not putting in the indication to treat dementia. They had to put to treat psychosis, or to treat hallucinations, things, or to treat anxiety. Otherwise, they were illegally giving it. So very important that we know that.
I have a quick question. If you go back to the slide before, you mentioned Huntington's chorea.
Yeah.
How does this help for Huntington's chorea?
Yeah.
Antipsychotic.
Yeah, it's because there are certain symptoms. Yeah. I'm not too I have to get more familiar with something like Huntington's. It's the words, but it has to do with some of the brain symptoms that happen that could mimic psychosis.
Okay, thank you.
Yeah. And I'm not sure. I gotta double check on the chemistry, but it suppresses emesis, which is throwing up. So they're pretty diverse medications, which is interesting. But again, it goes back to those things, those science where we find medications that can be used for other things that work. Like, ECT, electroconvulsive therapy, was originally for schizophrenia, but it turned out it treated depression better. So that's why it's used for depression more. We have what's called first and second generation antipsychotics, okay? And so basically that's the older ones and the newer ones. So the older ones where they work a different place in the central nervous systems. That's your Thorazine, your Stelazine, the old Haldol, things like that. Your second generations are the safer ones, fewer of those EPS side effects. EPS. So the dosing and the routes, it's not like this cookie cutter thing where, okay, you could buy a bottle of Tylenol, and if you're an adult, you take this many, okay? Because of the side effects that these medications have, this is why we have to take close attention to dosing and how they take it. Some people, they have a compliance issue because of their symptoms, and they end up having to get a monthly intramuscular or an IM shot, and that's where you get the decanoates and the depot shots. And that means they only have to come in like every 2 to 4 weeks, which is great for some people. I used to run one of these clinics where I gave shots of these antipsychotics, and the patients would tell me it's much easier than remembering to take a pill every day when I'm dealing with voices and things like that. So that's how we look at the different routes. The pills are the best, but sometimes, like with Haldol, if we use it in emergency, it's going to be an injection, so it's liquid form. Dosing, again, something with Clozaril. Have you heard of Clozaril, clozapine? Believe it or not, I kid you not, back in the 90s, early 90s, there was a show called Beverly Hills 90210. And in one of the later seasons, one of the characters was a girl that was dating one of the main characters who was on this drug called Clozaril. That's the first time I heard about it. He went with her to an appointment, and this is where I learned about Clozaril being a very dangerous drug for schizophrenia, but some people, it's the last resort. And it's the drug that can kill you if you get toxic on it. So that's where I learned about Clozaril, believe it or not. So you can learn a lot through pop culture. One of the main things about antipsychotics is the adverse effects, the side effects. Okay, again, lowers the threshold for seizures. People can have seizures, sexual dysfunction. You want to look for these adverse effects. If you have a patient, a long-term patient, either inpatient, outpatient in your private practice, who's on something called clozapine, it means they are registered nationally. Actually, a physician who is prescribing clozapine to somebody has to actually register it through a national office on the East Coast. Anybody familiar with anybody or anybody familiar with clozapine? Have you heard that before?
I've heard of it, but I didn't know it was dangerous. I
Yeah.
said I've heard of it before, but I didn't know it was this dangerous.
Yes, it is. Yes, it is. Of all the ones, clozaril is to schizophrenia and psychosis like ECT is to dementia. The person that is like does not respond to any normal treatment in depression ends up getting ECT. Well, in somebody that has not responded to any of the antipsychotics, we end up giving them clozaril. The physician has to send a special medication request to a national office. If it's approved, and this physician has an additional DEA number, if it's approved, they will register their patient with this registry, and there's a number that's given, and this patient is put on the clozaril. They pretty much have to get labs, they're supposed to get labs weekly. Like on inpatient, we had to have them weekly. The two main things well, the one main thing we're looking for in the labs is their white blood cell count. They can get it from agranulocytosis, which means they run out of white blood cells. What happens when somebody doesn't have white blood cells?
They can't fight off infection.
Exactly. White blood cells are your infection-fighting ones, okay? If you're on a medication that gets rid of those, guess what happens? You get infection. In nursing, we do a lot of vital signs, temperature, blood pressure. If we know a patient's on clozaril, clozapine, one of the first things we look for is a fever. If they spike a temperature over 100 and we know they're on clozaril, we do not give that dose. We get the doctor right away because we're looking at a possible infection, a possible bad side effect, okay? So that's why that's why clozapine is so touchy to work with. Another antipsychotic that we use, which is a newer one, is Geodon. The main thing with this is if you have a patient who's on it, we want to make sure that they have what's called a baseline EKG, which is they check their heart at EKG before they're put on it, so that there's something to compare it to if they start to develop heart problems. The heart functions on these waves. You've seen that, like the pictures when you see the heart waves is like that. One of those waves is a distance called a QTC, and they name them for a certain reason. It's a cardiology thing. But one of the effects of this particular medication is it can cause one of those to elongate, which is not normal. It can cause an arrhythmia, which affects the heart, which can lead to worse things with the heart. So that's why I mentioned that. Okay. Yes.
I had a quick question about with weight gain. So a lot of the young women, this is a huge issue, is getting on these mood stabilizers or antipsychotics and ending up 100 pounds heavier.
Exactly.
Becoming depressed over all of that. So what are some of the ones that are, more effective in maybe not causing that side effect?
That would be where you would want to talk to them about maybe talking to their doctor about getting the monthly shot. Like
so Invega and stuff like that is better at, like, they don't have the same side effects in terms of the weight gain? Okay.
Probably less side effects. I mean, these kind of medications will cause something if they're not monitored, but those kind of medications, one of the things that they're touting on these advertisements is less side effects or less troubling side effects. One of those is the weight gain.
Okay.
Mm-hmm. But yeah, that's one of the reasons why we give them with the shots, some of them, because there are less of those side effects.
Oh, okay.
Yeah.
Thank you.
Okay. Here's some more. This extrapyramidal, the EPS, very important if somebody starts having those. There's like the Parkinson's, or if you have let's say you have a client that comes into your office that's on these, and you see them start to do things like this. Or they're stiff like this, right? Or their eyes are going like this, or they're like got tremors and stuff. This is what's called extrapyramidal. This is a negative effect of these kind of medications on the nervous system, right? If this is not treated with kind of like an antidote, or if their dose is not adjusted, or if it's not reported, if it's left untreated, it will eventually get into this thing called Parkinson's, which is irreversible, and they will end up having Parkinson's symptoms. And then tardive dyskinesia, where they have movement disorders. This can all be permanent, which is very disturbing. The worst thing that will happen is the EPS will turn into what we call NMS, which is neuroleptic malignant syndrome. And just by the word malignant, it's bad. Okay. Mm-hmm. But these are the things that happen that, again, will kill a person.
Do you typically use cogentin to
Yeah.
counteract these side effects? Okay.
Yeah, cogentin is the most commonly used. We started using when I was working inpatient, we started using Benadryl because the cogentin itself had some side effects. It was like kind of like a pseudo antipsychotic, but it helped with the Haldol. So we would throw in 50 of Benadryl sometimes instead. So that has been, shown to be effective too.
Oh, okay. Yeah.
So if you're worried about the cogentin thing, then, maybe suggest they talk to their doctor about maybe something like Benadryl or something. Okay. This NMS is rare, but when it happens, it happens. I did have a patient once that had developed EPS a long time ago. It turned into NMS. He could no longer speak, eat. His cognition was off. He eventually died from it. So this is another one of those that, like the Clozaril, you stop immediately. I mean, you're not going to do the stopping because you're not the doctor, but immediately notify somebody. All right. And you educate your patient, you educate your client. Hey, if you're on this, let's say your client's on this, make sure you're monitoring. And this is why you want to educate your client. This is why. Okay. So those are the main things about the side effects of antipsychotics. Any questions? This is just something on toxicity. Again, you'll see that toxicity from these meds can be harmful, very harmful. So that's why us as therapists, we want to know this stuff so that we're the one that's in the office and our client comes in and there's some issue with the drugs, and you as a therapist can say, well, hey, let me show you this. I have been very fortunate to have been a psych nurse for all these years where psychotropics are my life. When you're a psych nurse, you eat, drink, and sleep psychotropic drugs. And so that knowledge has really helped me in my therapy practice because I'm kind of like a one-stop shop when it comes to knowledge. And so, again, that's why I push so hard. Somebody asked me, what seminars you want to do? I want to do the drugs. That's why I review the drug course for the MFT stuff. Okay. Again, there's treatments too. We were talking about some of them, the cogentin, Benadryl. This is the list of drugs. The ones in red are the ones that we use the most. The ones in the kind of shaded ones are old. They're very old. They're least safe, so we really don't use them. Again, there are some older people I've run into that are still on Thorazine. I just wanted to show you this list. There's a lot of meds out there, but the main ones are the ones in red. And again, you're going to get the slides, so you'll be able to have this reference. Okay. These are the newer ones. Again, you've seen these names before. Okay, I named them before. Again, they don't totally get rid of the symptoms. They make them more tolerable. These are the shots. Again, like I was saying, these three especially, if you got somebody that's having those issues, weight gain or whatever, maybe they need to be on a shot. The big thing with drug therapy, and I've talked about this throughout this talk, is ensuring that you know what you're doing as a therapist. You know this stuff about medications. What I like is that we actually have a psychopharmacology course in the MFT program, which is great. You're the one they're going to see. They're going to come to when they're in distress. You're going to be probably the first one sometimes to see side effects. You're going to be talking to families. You're doing family therapy. What if they've got one of their kids that's on an antipsychotic or even any of the other medications? You're going to want to be able to educate the family. Well, this is what's happening. What if, psych meds, it's a phenomenon. Psychiatric medications don't act as fast as Tylenol. They tend to get the side effects first, and then within like maybe 6 weeks, to start to get the positive effects. Another one of the adherence issues we have is they stop it because they got side effects. I've only been it for a week, but it's not working. Well, you as a therapist are going to, really should have the knowledge to know that, well, let me tell you why it's not working. This is how they work. This is why. You're going to get side effects first, so hang in there. Hang in. Call me more often if you need to. Where you might offer them that in between sessions contact for support so they don't stop their meds. It's like antidepressants. If they stop an antidepressant right away, they're going to get what's called rebound depression, where it comes back, but it's worse. And then you've got another problem there. Suicidal, things like that. Okay. The thing with women in pregnancy, you never want to have somebody who's pregnant in their first trimester to be on a psychiatric drug. It will cause the birth defects. If you have a client who comes in and maybe they're on one of these, not just antipsychotic, but any psychiatric drug, And then if you find out one time when they come in, hey, I'm pregnant, I'm so happy. If you know they're in their first trimester and they're on one of these medications, this is where you have that talk with them. The doctor talk to you about what happens if you get pregnant. You're not going to be able to be on these for the first trimester. So guess what happens? Anybody want to guess what happens? If they're not on their meds for 3 months, like they were never on them, they're going to come, the symptoms are going to come back full blown. That's called, this bottom one here that I'm highlighting, discontinuation. But these are some of the things for education. For you, this is what I want you to know as a therapist. Like I said, I'm not trying to overload you, but this is basic stuff for a therapist. Compliance, adherence, knowledge, self-management. Be the therapist that offers in between session calls if needed, like, oh my gosh, okay, let's get you to the doctor, or you know what, go to the ER, something like that. This is actually, I took this from your, those of you that are in the MFT program, I took it from your textbook, Preston. All right, any questions? That is the end of that one. Awesome. Well, hearing none, I'm going to say this. I want to thank you very much for being here. Oh, I heard somebody.
Yes, I have a question. So, or maybe I missed it. So if a client comes in for therapy,
right?
Are you in violation of HIPAA if you ask them for what medications they're on, or they disclose that themselves?
They disclose that themselves, but that should be part of your initial assessment.
Okay.
Yeah, you ask them because you're gonna, how you're doing that thing, you're filling out the forms and stuff. One of the places there should be medications. Because if you're treating with that,
and it's not a violation of HIPAA?
No. It becomes part of their record because you as a therapist, what's that?
Because they're coming to therapy for counseling, not, so they're separate. So that's why I wanted to see. If they're seeing a psychiatrist, I can see where they get asked for the medications and they're in alignment with what psychiatrists do. But with therapy, is that, so you're saying it's covered by HIPAA. You can ask the question if they're coming in counseling.
Yeah, you can. I mean, if they say, I don't want to tell you, well, then they don't tell you.
Okay.
So I ask every time.
It's just a natural part of my intake. It's part of my intake paperwork.
It
So
should.
if they choose to answer the question or not, of course, that's their choice.
Yeah.
Yeah, but I don't have it as just, it's not, for me, it's not just every, or for their intake, it's for every time. Every time I meet with them.
Yeah. Anytime you do it should be a standard thing with therapy because we're treating mental disorders as a therapist. So it's important for us to know what they're on in case any of this stuff happens, so we can help monitor, how they're doing in therapy with it. Like on my intake forms, I do online therapy. So the forms that I use from the company, there's a section there that says medication assessment. If I don't know what meds are on and we went into a problem or something, and let's say they come in, I want to ask them, how you doing and all that. I'm not doing so good. Well, it might be their meds or something. So yeah, if you don't go looking for it, then that's a HIPAA thing right there. If you look for it, but if you ask them and they tell you, then that's regular disclosure like anything else they would tell you. One of the things you want to ask in consenting is, would you be amenable to me being able to talk to your psychiatrist if needed, if it's a medication issue? If they say no, fine. If they say yes, great, get their consent to talk to their psychiatrist. So all that is covered. Did that answer your question?
Yes, thank you.
Okay, sure. These are the resources. So I put a bunch on here, of course, the APA. This book at the top with Procision, that's the big, like my Bible of drugs that I want you to, at least have access to. I want to thank you all for being here. Hopefully all of you were able to get in. This will be made available to watch again. And again, there should be evaluation forms that you fill out, that you send in, I think, email in. As part of signing up. That's what I was told. And again, I put my email in the chat. I'll do it again. Karen.wall@wisr.edu. Did everybody see that? That's my email. And yes, Christine, what you said is very true. We have to assess the whole person. And if they're on medications, that's part of the whole person. For those of you who came in a little later, I had some housekeeping. Make sure, because I couldn't write everybody's stuff down, I would love it if you would email me your name, your license number, especially if you're getting CEU for this, your email so we can send you your certificates. And if you have any questions you want to ask me in an email specifically, feel free to do that. And also I will make sure that if you want copies of this, like the copy of the PowerPoint, put that in your email and I will send it to you outside of having the recording you can watch, so you can have it, and I will send you any other resources you want. Anytime, keep my email. Anytime after this, if you want to contact me with questions or if you just want a resource or something, I will give you whatever I have. My stuff, I love it when it grows feet. Well, I give you permission, you know. Use this PowerPoint if you need to, whatever, okay? So thank you again for being here. I really appreciate it, and I'm honored that you signed up. And hopefully I will see you at future seminars. Hopefully I'll see some of you, if not all, at part 2, where I'm going to talk about addictions. Okay?
Well, thanks, Karen. Very
You bet.
helpful.
Good for you. Thanks a lot. You guys take care.
Thank you.
Happy Thanksgiving.
All right.
Thanks, Karen. So
Okay.
helpful.
Take care.
Bye-bye.
Thank you.
You're welcome. Take care and have a good Thanksgiving. I hope to see you guys the next time.
Okay, thank you so much.
Okay. Bye-bye.
Bye-bye.
Bye, it was very informative. Thank you.
Thank you very much. Bye, James.
Bye-bye.